Yes. Anyway, I was about to introduce the transthoracic echocardiography, which actually is not very interesting considering the ejection fraction is around 50% with some mild inferior mid-basal hypokinesia. This patient has been referred to cardiac MRI before actually entering the cardiac lab. So the report from the MRI is ejection fraction 47% with some infra mid-basal wall akinesia, basal inferior dyskinesia, and during pharmacological stress, there was septal anteroapical inducible ischemia. So just to refresh, he had an inferior STEMI 20 years ago. So that's the MRI. As you can see, there are some, some results of the previous inferior MI. You can see that the ejection fraction is almost normal. And in this view, in the short axis, you see clearly what happened 20 years ago with this akinesia in the posterior wall. Let's have a look at the basal angio. So the right coronary is honestly without any interest for us, but the interest is coming. So that's the problem for this man. There is some kind of tight stenosis of the ostial LAD, obviously involving the left main, but also some disease of the proximal part of the LAD. And I want to show you again some disease involving also the ostium of the circumflex. These are some numbers and calculations, as you can see. Of course, there's no time to express our concern, my concern in particular for these numbers. However, if you look at the total symptom score 1 is 23, meaning that this patient will probably be better treated by means of cabbage. If you look at the syntax score, the number is 41. So the syntax score 2 says that the treatment recommendation can be either cabbage or PCI. But if you look at the syntax score 2020, there is, I would say, a wide difference in terms of 10 years mortality, well, as compared to cabbage and PCI. But of course, as we are here, and this patient has been referred to PCI from the attending physician. But it's time, I guess, Alaide, to discuss about the strategy. So I'll show you again what's on the menu, and I leave you the word.
Okay, so clearly we are in ABC, and our belief in ABC and from all the consensus that have been published, and I'm a fully believer and follow the group, is provisional, which is not just put a stent across, and it is always important to remind, but is the stepwise approach that was also recently published, and it was in the EBC main. So personally, I would stent across, clearly protective both branches, stent across, then doing a pot, recross, and then eventually kiss. But this is clearly, again, very big part of discussion. And then clearly, which stent? Are all the stent equal? And another question is imaging. I mean, I would personally do imaging, and I don't think all the stents are the same.
I would agree with that. I think the key issue here, though, is imaging up front, isn't it? To really take out some of the ambiguity that the angiogram is providing us, because what's not clear is how heavily involved that circumflex ostium might be.
Exactly. Well, no. Anyway, so these were the calculations, the strategy we discussed. Of course, we proceeded with using a non-compliant balloon to predilate the proximal LAD, and then with the implantation of a synergy 3/24, followed by the post-dilatation with non-compliant balloon with 3 millimeters, and then we use the Megatron 4/20 to treat the ostial LAD and the left main stem. As you can see, we actually position it in 2 views as usual. That's very traditional, nothing special about it. And then a kissy balloon, because as Alaide pointedly said before, of course, we used a stepwise approach. And in this case, I think it's really appropriate to use a provisional T because the lesion into the ostial LCX was not that important, although, of course, there was some involvement, but I would say that lesion was around 20%, so nothing special. So pot technique with the NC balloon 4 millimeters, and then that's the IVUS run. As you can see, is relatively short, so I'll let it go. But the numbers are on the right side of the slide. As you can see, the left main shaft has been measured around 6.5 millimeters square. and then the proximal LAD was 4.3 millimeters square. It is obvious that those numbers are not enough. So we proceeded with another post-dilatation with non-compliant balloon 4 millimeters for the ostial LAD, and then 4.5 for the left main stem. And then we proceeded with another IVUS. And with another IVUS, of course, that's what we obtained. So 11 millimeters square for the left main shaft and 7 millimeters square for the proximal LAD. So in other words, we achieved some numbers that nowadays are considered to be acceptable in terms of guidance done by the IVUS. And this is what we should discuss now, because of course, there are a lot of criteria, but those, I would say, mostly used worldwide are those coming from the Asian experience and the other coming from the Caucasian experience. However, in the case that I just showed you, the number were actually consistent with both. But of course, there is a lot of debate around what is the real, or let's say, paramount numbers we should consider. Nevertheless, I would say that is something that we are still testing, because at the end, of course, this trial, well, this patient has been enrolled in a trial, and this trial, of course, required a very specific protocol. This specific protocol has been summarized in the optimal trial. I'm happy and honored to be the PI of this, and this is still ongoing. We are just surpassed 220 patients. This trial is actually ongoing in UK, Italy, and Spain. So we are trying to demonstrate that the IVUS should be routinely used, imaging, and actually IVUS should be routinely used in the treatment of left main. But of course, waiting for the data, we'll try to confirm what is our hypothesis. These are my takes on. The IVUS should be part of the routine, and pre-specified IVUS goals are paramount, because you must use IVUS and use the data coming from the IVUS, meaning that the IVUS data must be actionable. The optimal trial has been designed to demonstrate in a randomized adequately sized population the favorable impact of this strategy on clinical outcomes. That was the end and open for the discussion.